I think it'll be good to open the discussion for the four of us to talk about sort of, now that the Nexus platform is coming out, where we see this taking our practices. So I don't know, Izzy, if you want to start out.
I really like the versatility. I think this is going to allow me to do many more things that I just could not do or was too afraid to do. We're able to reach around corners now. Uh, John pointed out using navigation to guide this even better. We can come into the operating room more prepared, and we can come into the operating room with a sense of confidence that we know this is the piece of bone we want to remove. We're going to be able to remove it. Or like in your case, Tiffany, this is the tumor that's squishing the spinal cord. Now I know I can remove it safely. So it's going to provide versatility. It's going to allow us to do more things that, quite frankly, 5 years ago, 10 years ago, and 15 years ago, we would have deemed non-operative. We would have deemed unable to accomplish.
Dr. Cantor or Dr. Asghar, do you want to comment on where you think this will help take your practice?
Well, John, you want me to jump in? Or you want to jump in first? Well, long term, I think that at some point in time, they're going to have to strap a ultrasonic Misonix cutter on the end of a robot. And quite frankly, the robotic technology, the really moving long, way down the road, this is going to be the way I think everybody's going to be going. It's moving pretty rapidly in that direction. I use the ultrasonic tools for every operation I do. And quite frankly, I very rarely use a Kerrison. I don't use drills. It's all done ultrasonically. It's really opened up opportunities to do things very, very differently. We've cut down fusions almost probably 80 to 90% for lumbar decompressions and cervical decompressions. The tool allows you to do things that you just shouldn't be able to do. You can have a bone spur from a posterior approach sticking into a nerve root anteriorly, and you can safely dissolve that bone spur out of the nerve root. You can create space, and Tiffany, you showed a real good example in a tumor, how you can create space to implode compressive lesions into the spaces that you create. With these tools, we can create space in vertebral bodies and remove bone spurs that are pressing from an anterior to posterior direction by creating holes in the bones and allowing those to be opportunities for doing things, again, that we shouldn't be able to do. So we're designing new operations. We're changing the whole process of how spine surgery is done. And I think it's ultimately going to be something that everybody's going to adopt. And I think it's a good time that folks that aren't using it hop on and start kind of getting on the train, because it's for real. It's going to happen. All the big companies are looking at this as the way to move forward. And that's kind of where I see things going.
Dr. Asghar, how about you and your deformity practice with pediatrics and adults?
I love it. I think what it allows me to do is allows me to be creative in how I do my osteotomies now. And that's the part I like the best. Like traditionally, you had PCO, PSO, VCR, but now there is, hey, can I use this disc space that has a little bit of bridging bone to allow me to get a deformity correction? Can I change the tip angle and come in from a slightly different trajectory to work around this space, which I wasn't able to do before? And so for me, it allows me to be creative in a way that I haven't been able to do with the traditional drill or a traditional Kerrison and in traditional techniques. And that's what I find so nice and exciting about it. And then all the technology that develops around it is what's really going to kind of take it to the next level. So.
Yeah. And going back to what you stated, Dr. Cantor, I loved the concept of creating space. And I think that one area we haven't really touched on, but in thoracic disc herniations, obviously it's so nice to be able to go in with the Misonix instead and create a space in the bone, if you would, so we can pop that disc right down or tamp it down with an Epstein curette into the space that's created. because I hated taking a burr in there. You know, as a neurosurgeon, that you just cringe. And Dr. Lieberman was talking about his heart rate going up watching a fellow or the resident with the tools in their hands, and mine would go up even though the tools were in my hands. But now with the Misonics, I feel like there's so much more control. There's so much more accuracy that we can have with this particular instrument, which is critical to our practices. So, where do you think that Nexus can take us? You know, one of the things that I've been wondering about, and I'm curious, Dr. Cantor, how you do this. You never use a Kerrison, even though I do my bony work, and I typically do about 80% of my practice is revision work. I still have to use my Kerrisons to remove ligament, to remove, you know, scar tissue, soft tissue. I don't use a soft tissue debrider, but that's one thing where I wondered if the Sonic One would be able to do that, and potentially, instead of being able to use it for soft tissue debridement, mostly in, you know, foot or orthopedic procedures, if this would potentially be something that we could use for ligamentum flavum or epidural scar tissue.
Well, the statement "I never use a Kerrison" is not 100% accurate. I do occasionally use a Kerrison to remove a piece of ligament that I freed up with the ultrasonic cutter. What's interesting is normal bone has a certain density, and arthritis has a softer density most of the time. So you can create planes between the normal lamina and the ligament and the hypertrophied facets very quickly and very efficiently, where you can literally just dissolve that plane and take a pituitary and pull out the entire ligament in block. Mm-hmm. And that picture that I showed you earlier was a case where we go inside, we dissolve the ligament off of the surface of the bone in a place, it's kind of like taking bark off of a tree, and you take a pituitary and pull the entire ligament out, and you can see the anatomy of the ligament because you can take it out at 2 or 3 levels in one piece. And you could do it quickly. You could do a 3-level decompression in 10 minutes. No blood loss, extremely fast, and then you can direct your osteotomies to the opposite side facet just by designing the anatomy. And the way I learned how to do this is I actually took the O-arm and practiced in our lab doing these procedures without removing the lamina, and just learned how to design operations where you have directed cuts towards the opposite side, where you can detach the normal attachments of ligament without ever having to be touching the dura.
And are you doing this with the BoneScalpel, the actual blade, or are you doing this with one of the hooks?
Blade.
Okay.
You never should, when you're doing these decompressions inside the lamina, you really should never get near the dura. You're working in the bone, between the interface of the bone and the ligament, and also inside the soft cancellous bone, which is what bone spurs are formed from. So you really can work inside the bone without ever having to remove the opposite side. And the difference in pain when you do a unilateral access bilateral decompression versus a bilateral access decompression is pretty dramatic. The narcotic use in these operations is much, much lower than it would normally be. So we really don't need Kerrisons to do decompression. Sometimes you may grab a piece of ligament that you freed up, but you don't actually need the Kerrison to remove the ligament anymore.
So Izzy and Dr. Asghar, how do you remove ligament and or epidural scar tissue? What are your tricks, your tools?
Coming to me? Typically what I'll do is either use a combination of the blade or the hook, much like your strategy, making room. So I'll undercut the lamina, undercut the lateral recess, the superiorticular process as much as possible until I find that free edge of the ligament. And then I'll use a small curette and just sort of peel off the rest of it and pick it out. Much like Jeff described, I pick it out one large piece, and it's pretty satisfying when it comes out in that one big chunk, and then you watch the dura re-expand because you still see that little bit of hourglass in it, and then it just sort of re-expands. But that's a typical case. The revisions are a little bit more difficult with the scar tissue because there's always something stuck to it, so you end up pulling a little, teasing a little, pulling a little, teasing a little until you get it out. But it's still go from normal to abnormal. Take off bone until you find the free edge of the ligament, and then resect it, take it out, lift it out, whatever it may be.
Dr. Asghar, do you have any tips about your soft tissue work?
Yeah, I mean, I think very similar to what Dr. Cantor had said is I think a lot of times you can find a plane between the ligamentous attachments, and actually even in the soft, if the epidural scar, if you work right in the plane, there is an area of that you can safely work at that divides off and separates away from a lot of the things. And then what I'll do is once I've created that separation, I'll, very similar to everybody else, I'll use kind of a combination of a nerve hook or a curette and kind of pull things slowly off of the rest of the way. But what I do find is especially, again, not in cases where things are ossified, but if you have, like in things where it's just scarring, which is sometimes a little bit different, you can find a nice plane to work between the dura and the bone, and it peels off quite nicely that way.
So currently we're going to transition. We use this for so much. We use it in cervical, I use it in cervical laminoplasties, anterior corpectomies in the cervical spine. Dr. Lieberman mentioned using it laterally. We use this dorsally as we do our deformity corrections, PSOs, SPOs, VCRs. Is there anything we're missing? Where can we go with this? What are we looking at down the line?
Well, I think where we're going down the line is what we talked about earlier. Is I think we need to use this with some of the new emerging technologies, the augmented reality, robotics. This allows us to make safe precision cuts without actually seeing where we are. So you don't have to see where you're working. Once you get the hang of this, you can work in safe zones and safe planes. So that allows us to strap these things on the end of a tool that can design these cuts and really do much different operations. You talked about a little bit earlier about anterior cervical. What's fascinating about this is in the past, everybody is really, you get really scared about, injuring the vertebral arteries, doing far lateral foraminotomies. With this tool, I've, in many cases, literally dissected the lateral, the uncovertebral joints far enough laterally to see the vertebral arteries without worrying about it. And you can see the nerve root completely exit. So we don't do a decompression anymore. And, patient still has pain. You get a CT scan and realize, hey, I didn't get far enough lateral. And it's a whole different process. What's interesting about this tool is you don't learn it in one day. This is kind of like somebody who's used to swinging a baseball bat with their right hand and saying, I can teach you how to hit the ball better, but you need to change to your left hand. It's that different. And it's also interesting, Izzy said that earlier, that he tells the residents and the fellows not to touch the tool. I've told John exactly the opposite. When we first started working together, you need to touch the tool and you need to feel how it feels on your fingers. Now, I wouldn't tell your resident to take this tool and jam it into your finger because it will slice your finger off. But if you just get in the habit, if they just get in the habit of just literally like dabbing it on and just almost like an electric toothbrush and feel how it generates heat, feel what the tool does. I actually have practiced taking a piece of bone between my fingers and practice dissolving that piece of bone and how fast you have to move and how you have to use the water flow without burning my finger. And that's a way to learn how to use this tool. So John showed earlier practicing shelling an egg. We blindfold and you shell an egg. Well, that's how you learn the tactile sense of how this tool works. And you can use this tool. I use it 100% of the power at 100% irrigation all the time. And quite frankly, I don't care if I can see. You know where the cut is. It's pre-measured. You know exactly where it is because we don't do a decompression where we make a hole and we start clipping away with a kerosene. The cuts are measured. I actually take a caliper and measure exactly where the cut is and just cut. So we know where the pedicle is, we know where the facet is, we know where the structures are. So it's all designed before we make an incision. So it's a matter of, okay, from this particular landmark to this landmark, it's 3 millimeters, and that's where that joint, that facet spur is going to be. And I just do it, and it takes a minute versus looking for it. So I think the whole process takes a long time to learn. I think the reason it's not catching on is because everybody sees water and they think it's spinal fluid and they get scared of it. But just put it in your hands and play with it. Learn how to use the tool. Learn how much power it has. Learn when it burns your finger and when it doesn't burn your finger. I don't know if everybody agrees with that, but it's just a different way of looking at it, and it has worked for us.
Yeah, and I think on that note, we had a surgeon that came out and did a big presentation on endoscopy in the spine and the learning curve, and his learning curve was about 150 cases. And I think that I would bore myself to tears if I had a learning curve 150 cases with endoscopy. And I really feel that he was, showing films of how you could do a great bilateral decompression from a unilateral approach with endoscopic work. And I really felt like with my sonics, I'm able to do a unilateral approach, bilateral decompression, and I'm underwater. I am very safe, even though I may not be able to have that visualization or have a small camera in there. I feel very comfortable. I'm not going to injure anything. And I feel like in some respects, this is almost a competition for that, because you really can, through a very small incision, get that bilateral decompression, not visualize necessarily, but know that you're safe in what you're doing with appropriate cuts. So Izzy, you teach fellows and residents. What are some of your tips and pearls to fellows and residents in learning how to use this device?
Well, in my world, John, if I told the fellow to touch the blade, I'd be charged with some kind of harassment. And so I tell them not to and let them figure that out on their own. But I do like your tactic, and I think I am going to use that tactic of holding the piece of bone between your fingers. That may be a very good training tool. The one thing I do tell my fellows, and Tiffany, probably unlike your fellows, orthopedic residents and fellows, we get the occasional neurosurgeon, but they're a little bit simian, and they grab tools with all the force. And I tell them, hold it like a paintbrush. It's not really hold it like a paintbrush and feel it and get to use it, and don't force it into something. So don't let that blade bind, and don't let that hook bind. So those are really the two big things. And yeah, at first you got to be patient with it. You're not going to remove all the bone as fast as John or Jeff can remove it with doing 100 cases, but you're still going to be much more efficient than what you pointed out with some of the endoscopic technology and some of the shielded burrs that are now coming out that they're touting can be used for foraminotomies. They just gum up. They just fill with tissue and debris, and they don't empty, and you end up making multiple passes in and out. I found those far more cumbersome. So I tell the fellows to practice with it, be patient with it, hold it like a paintbrush, and really learn what you're doing with it. Much like what Jeff had mentioned. And yeah, I'm going to use that. This is what's great about this webinar. I learned something from Jeff tonight with the piece of bone in the fingers. I'm going to try that.
Well, what's interesting is what you just said is probably the smartest thing that anybody's said so far is be patient with it. The tendency is to, when you're cutting the bone, you kind of get like, hey, this is taking a while. Let the tool do the job. You should never be pushing on it. And particularly when you're doing posterior cervical, literally the cut should be parallel. You should not have one area that's deep, and so you should start at the top and work to the bottom and cut, from the top of the lamina to the bottom, never plunge. And when you do that, interesting, as you just dissolve, it'll kind of all go through at the same time. And you kind of get impatient, and that's when you're going to start to burn. That's when you're going to start to potentially get dural injuries. So again, what you said about being patient is the best description on how to learn how to use this tool.
And I think the other thing is not working or housing yourself in one particular location with the blade. Typically, as you said, we can have somebody who really wants to get through. So you know the depth, and that's the worst thing you can do, because then you're working in this deep corridor. The Misonix does not irrigate properly that way. It does not allow to cool the irrigation to cool the blade properly that way. And it really doesn't serve a purpose, because the ultimate goal is to get all the bone off in one smooth cut. So I think that movement, and I encourage my trainees as well, just to move around. Don't park yourself in one place and work like we do with the burr. Typically move around so that this doesn't heat up. How about for Dr. Cantor and Dr. Asghar, do you guys have any particular tips and pearls for the device that you want to share?
Well, for me, I think one of the big things is early on, don't bite off more than you can chew. So a lot of times the learning curve for me was I would make these big cuts and I would try to take a big chunk of bone because I'm an orthopedic and I want to show off how much I can take at one time. And what I learned was smaller slices, especially when you're doing an osteotomy or a decompression early on, is better, it's safer, and in the end, as you get comfortable with it, you'll realize that it's much faster to do it that way as opposed to be too aggressive with it. The other part of it is as you start to work more from posterior to anterior and around corners, tactile feedback matters. So just making sure that you understand the distinction between the tactile return of what cancellous bone is versus what cortical bone is, and kind of the differentiation of those planes. Because if you start doing a PSO or something that is a 3-column resection and you start to get into the front of the body and you are not feeling things quite well, that's where you can get in trouble. And then making your sweeps nice and broad as opposed to try to dig into a hole, which is something you've mentioned as well.
Yeah. Well, I think we're at time, so I want to thank everybody for participating. Dr. Asghar, Dr. Cantor, Dr. Lieberman, I really appreciate it. And I feel like we all learned today, which is good.
Awesome. Thank you all, colleagues. This was fun.
Thank you, guys.